Assalamu alaikum. Okay, we had this case. So this is the case that the patient had deciduous tooth, صح?
Not deciduous, microdontia.
She has microdontia, but she had a retained deciduous, I remember you told me. And then they found that the canine is not present? Or
No, the canine was impacted, and she
Impacted?
did, she did orthodontic treatment.
Then, where is the canine now?
Surgical
Where is the canine now?
extraction, because
Why?
it's failed. Orthodontic
Failed.
treatment, yeah.
They failed. Okay. So it was the case of the impacted canine, and they tried to take it out, but it failed, so they extracted the canine.
Exactly.
This is the space now is excessive for one canine. Although the teeth have been adjusted orthodontically, we see the microdontia around, okay? And we have decided last time that we're going to do it either removable or implant, we said. We're not going for
Removable
bridges.
is temporary for implant.
Why didn't we not go for bridges? We have very small clinical crowns, okay? The clinical crowns are very small. The retention area is low. And then we also have the canine. It's in a critical area. And we also have spacing between the teeth. We could not mimic the spacing with the canine, with the bridge. Okay. So we went for removable as a temporary, and then
do implant.
implants. Okay, she's young. How old is she?
I think 22.
Okay, she's 22. So she has time to decide or have money, because most of our problems with our patients, they don't have money financially. They could not support having an implant. Maybe at a later time she will take it. So we'll do a partial. The partial will benefit us here in deciding how much soft tissue and bone tissue we're going to replace, because you see the depression here. Okay, so let's go for partial option. Now we're discussing what to do next. You're talking. Tell me what is the design. I told you go downstairs and do survey line. What did we find? We have no undercuts sufficient and far away suitable for partials to retain. So what are our options for retention now? So all of the buccal surfaces, their undercuts are very close to the gingiva. I could not place the clasp away from the gingiva. So what are our options for retention? We don't have, in general, we don't have undercuts. What are our options for retention?
Clasps.
Okay, good. Okay, clasps. We don't have a retention. And I know if you're going to do lingually, also you don't have them as well. You don't have undercuts lingually. If we have undercuts lingually, we can replace the undercuts by engaging. There will be a clasp, but it will be a reciprocal clasp, and the acrylic going into the undercut is the retentive part. But I know if you're going to do it, just looking at this from vertical, I will tell you, you will also don't have palatal undercuts. You don't have buccal and you don't have palatal undercuts. What's the options? One is getting friction. Okay, so the way we're going to go with our acrylic, we will utilize proximal undercuts going in with embrasures. Yes, embrasures in between spaces. But we how much are we going to engage? If the patient smiles, I don't see the pink color. So I'm engaging the embrasures, okay, going into the palatal embrasures, but without the acrylic showing through. So this is utilizing friction. What other option do I have? Can I trim in the teeth? Can I make an enamel dimples, for example, or not? For example, no. This is a transitional RPD. I'm not allowed to trim teeth or remove from the teeth or prepare teeth. What option? The option, I could build them. How do I build them? Suppose I'm going to do a design where my clasp, for example, is going on the premolar, for example. I could do my ideal clasp design away from the gingiva, cleansible, going into the embrasure and whatever. And once I place it clinically, suppose it ends here, over it I place a spot of composite. So I acid etch in the spot, I put a bond, and then I add just a small bit of composite. It will create an undercut. Okay, so how are we going to place the composite? Can you hold the camera please, just a minute? Okay. Suppose I'm going to, this is my clasp. Suppose I've chosen to make a clasp like this, okay? Or better, whenever I have an option to make the clasp, make it coming from distal to mesial. Why? Because when it's going like this, whenever the patient wants to put the RPD inside the patient's mouth, it will keep hitting the lips and injuring him. While when they tilt like this, when they want to enter with the partial denture, the round part is touching the lips, so it will not injure them. So let us take the best option. Okay, maybe I don't want to extend to the last tooth. Let's say we're going to end here. I'm going to do an ideal clasp. So let me do my design like this. The clasp comes like this, parallel to the gingiva, leaving enough clearance beneath it and ending into the embrasure and ending in this area. Okay, I know that I don't have an undercut here. So how is it going to retain itself? After I insert it in the patient's mouth, I mark the area above it. I take out the RPD, I acid etch this area, bond it, and then put a very small dot of composite. If it was a flowable, I will put a drop of flowable composite. Cure it. Cure it. What will happen? It will come like a veneer and it will create an undercut. Okay? I do one here and one here. Once more, I want to do a mesial clasp better. Once more, not to injure the gingiva when the patient is inserting. So coming from distal to mesial. Okay, let's say I'm going to use this undercut. So I place my clasp, I bend it, wire bend it perfectly parallel to the gingiva with the clearance. It ends here in the embrasure. I make my composite dot here.
Yeah, I've got it now.
But not over the clasp when it's inside the patient's mouth. No, the clasp is outside. And I place an acid etch in that area, then a bond, and then a drop of composite, flowable composite, or a small bead of composite if it was in the gel form, not the flowable form. Okay, and then cure it. So it is reversible. In any time I could remove it, and it saves the tooth not being prepared or trimmed. Okay, so this is how we're getting retention. There is another retention we will get from engaging the undercut here. There is a small undercut here. Definitely we're going to replace the bone by the gingiva colored acrylic, the acrylic in the saddle area. It will replace this shape, and it will keep the finish lines, because look at here. This is the gingiva line for this tooth, and this is the gingiva line for this tooth. I want the acrylic reaching here. Okay, gingiva line. All of this will be filled with acrylic. So once I'm filling this, there's a very small undercut here. It will be engaging in it. So the patient will insert the denture from here and then click it into place. Okay? So it's a tilted path of insertion. The path of insertion, I'm going to design it to come from this side. Okay? And teach the patient to wear it from this side first and then click it into place. So this is how we create dentures retention. Thank you.